Infertility is defined by a couple having sex with the intention of getting pregnant for over 1 year. Most couples will conceive in the second year, but a diagnostic workup for why they're not able to conceive should start at 1 year. A couple of things that might bring that number down, particularly advanced maternal age over age 35. And it's going to be counseling first. Make sure they're having sex the right way. Make sure they're having sex at the right time. Make sure they're not having continuous sex through the entire month and that they're targeting ovulation. So a lot of it is going to be coaching. And when you begin to evaluate someone, remember, you want to blame the guy first. By the numbers, it's more likely to be a woman problem than a man problem. But there's this whole basket of 25% unexplained that I chalk up to being the guy. The point of this is that there is a stigma against women that somehow they're able to control whether or not they get pregnant and may even be able to control the gender of the child. You want to dispel that immediately on presentation. And then, if they're really having difficulty conceiving, 1 year is the number you want to use, you begin the infertility workup. So if someone comes in complaining of infertility, the first thing you're going to do is blame the guy. Probably the dude's fault. And so you work up the male problems first. And you're going to have issues with obtaining and achieving erections and being able to ejaculate. Then you want to make sure the sperm are sufficiently motile, that is, they're actually flagellated and in good number. If you have a problem with this, it's the guy's fault. And we have lectures in subspecialty surgery about urology. What it really means is male urology. So check out those lectures if you want to know more. As a quick drive-by, what you want to consider in erectile dysfunction is whether or not it is psychogenic or organic. You do that with a nighttime tumescence. The idea is, if it is not organic, there will be spontaneous erections at night. So you put a roll of stamps or a taped piece of paper on the penis, let the guy go to sleep. If he wakes up and it's broken, it means that he had nocturnal erections and it is not organic. You treat psychogenic with counseling. It means that he just can't get it up with his partner. That's going to require them talking it out. Organic erectile dysfunction is going to be treated with the phosphodiesterase inhibitors. Sildenafil, sildenafil. There's some other surgical stuff you can do, but that's not going to come up on an infertility question. And then if there's an issue with count or motility, then you have to consider artificial insemination. And let's spend a little bit on artificial insemination just so you know about it. You will not be asked to choose between them. I just want you to hear the words so that when they come up, if you go into an infertility clinic, you'll know what they're talking about. Intrauterine insemination is essentially where you take concentrated sperm in a turkey baster. So the woman has to do nothing to prepare for this. You take a bunch of ejaculate, you wash off the prostaglandins, you hyperconcentrate the sperm, and then you bypass the cervix, dump a lot of sperm into her uterus, and effectively let the normal course happen thereafter. Easiest on mom, least effective. In vitro fertilization is where you have to put mom on hormones, and you harvest some eggs, and then you mix them with a bunch of sperm in a dish. The fertilization happens naturally, you just happen to bring the egg and sperm together, and then you re-implant the zygote back into mom. The most advanced and the most complicated is ICSI, intracytoplasmic spermal injection. You put mom on hormones, you harvest some eggs, and then you take the sperm and actually inject it into the egg, forming a zygote. You take that zygote and implant it in mom. Efficacy increases as you go up, complexity goes up, cost goes up as you go down. So just know that these exist And I'm going to use the words artificial insemination as though interchangeable with all three, because you won't have to choose between them. But if the male issues are not the problem, that is, all this stuff is normal, now we got to blame the woman. And we got to find out what's wrong and fix it. The first thing you're going to do is a mucus workup. The idea here is that at the beginning and end of a cycle, the mucus is hard. And that makes sense. Right? It should be inhospitable most of the time. She's not trying to invite infections of her cervix, and she's trying to keep her uterus sterile. So most of the time, cervical mucus is going to be inhospitable, hard, and kill stuff. But at the middle of her cycle, right around ovulation, and I'm just going to assume a normal cycle of 28 days, so I'll be referring to hard days, meaning day 14 is ovulation, based on 28-day cycle. At day 24, it should turn soft. Teleologically, that's her body saying, we got to give it a chance if we're going to have any kids, so make it a little less inhospitable, let some sperm in. The way you evaluate this is by having the couple have sex sometime around ovulation before they come into clinic. Then you're going to take a sample of that mucus and do a smush test. You'll literally just take the mucus and put it on a slide, put another glass slide on top, and then pull them apart. Soft mucus stretches, hard mucus breaks. And so if you're only able to get less than 6 centimeters on the smush test, or you look under a microscope and you see no sperm, and since you've already evaluated the guy, you know his ejaculation has enough sperm in it to be seen, or you have a negative Fern sign, and Fern sign is just a reaction to estrogen. If you see evidence that this is hostile mucus, that's probably the problem, because at this point it should be as most hospitable as it's going to get because they're having sex near ovulation. If there's a problem with hostile mucus, you can treat with estrogen, since estrogen ripens the mucus and gets it ready for the sperm. Or if you're not going to put her on hormones, you can simply bypass the mucus with artificial insemination. And since this problem is probably just at the cervix, it's going to be intrauterine injection bypassing the cervical mucus. That's the most likely to be successful. And it's also easiest for mom. But if you're able to get greater than 6 centimeters on the smush test, there are sufficient sperm, and there's a good Fern sign, that's normal and has nothing to do with the mucus. Then you want to assess whether or not she's got good ovulations. Because if she is anovulatory, you're able to push her into ovulation using medications like clomiphene or Pergonal. Clomiphene being preferred. The way you're going to assess ovulation is both serologically and physically. The easiest way to do this is a basal temp, and people who are doing pregnancy planning will use this method. At ovulation, what happens is there's a spike in the temperature, and if they don't get pregnant, it comes back to normal. If there is a spike of temperature and they do get pregnant, it'll stay up. But the whole point is that there's this temperature rise of about 1 degree of body temperature. And that's a good way to plan when to have sex, to try to figure out when ovulation is occurring. Not really if. The best way is an endometrial biopsy. Anywhere in the back half, day 14 to 28, where you should see a secretory uterus. That's pretty invasive and usually not necessary. Using serology and urine tests is usually sufficient. You can also get a progesterone level anywhere in the luteal phase, generally day 22, and it should be elevated. There are available kits over the counter which test for urinary luteinizing hormone, which does a pretty good job of sensing serum luteinizing hormone. And in this way, you'll be able to identify, yes, the ovulation is happening. But you'll also be able to identify this on the patient history. If somebody has irregular menses or has evidence of PCOS, you can be reasonably sure the problem is anovulation, and you'll be able to help them using medications like clomiphene. But if you're asked to define whether ovulation is happening, you can use these tests. But if she is ovulating well, then we know it is not ovulation that's the problem, and the next thing we need to assess is her anatomy. To do that, we're going to use a hysterosalpingogram. Hysterosalpingogram. And basically, you're just going to visualize what her uterus and tubes look like. On this side is a normal uterus, tubes, and ovary. On this side is abnormal. What you're looking for is any sort of anatomical defect, which could be bicornate uterus, some problem with the septa, fibroids, a stricture. It doesn't matter what the anatomical defect is. If there is an anatomical defect, it's going to make implantation really difficult. And so you might have strictures from pelvic inflammatory disease, you might have fibroids, or you might have some problems with Mullerian structures. And I'm saying that because it doesn't matter what the structural problem is. If there's a structural problem, there's a structural problem. So if you happen to have anatomy positive, it's generally a problem with implantation, but it may be a problem with getting the zygote through the fallopian tubes. If you have a problem with anatomy, surgery can be an option. Tuboplasty, trying to put the tubes back together, or some form of artificial insemination. You will not have to choose between the different surgeries that are available, but basically what you try to do is reconstruct the normal looking uterus so that the zygote has a place to implant. If it is anatomy negative, your last ditch effort is endometriosis. So you're going to do a diagnostic laparoscopic procedure, looking around, trying to find something. And if you find endometriosis, and endometriosis generally does not present with asymptomatic infertility. Generally, there's going to be some sort of menstrual pain, abnormal bleeding, something that tips you off. But if you're here and you find the chocolate cyst and you see it, since you're already in there doing the diagnostic scope, simply do laser ablation. You can also try OCPs and estrogen. We talk more about endometriosis later in this course. But if the diagnostic lab doesn't reveal anything, then you're at unexplained fertility. And at this point, it is generally considered cosmetic to get pregnant. And what I mean by that is a cash business. So you're going to combine some form of clomiphene protocol with some form of artificial insemination. And this is going to end up either with a surrogate or some sort of artificial insemination of mom. The answer on the test, if you get to unexplained infertility, is adoption. You got plenty of kids looking for home. It's way cheaper to do adoption than it is artificial insemination, and this is generally considered cosmetic. So the test is going to want you to pick adoption. Now, the couple may not want that, and if they've got the cash, they can do it, but right answer is adoption. So before we close, I want to briefly go over the axis again because it's important here and how clomiphene and Pergonal work. The hypothalamus stimulates the anterior pituitary, which stimulates the ovaries. The ovaries then cause proliferation of the endometrium. The hypothalamus does this with pulsatile GnRH, stimulates the anterior pituitary to make FSH and LH. The ovary makes estrogen and progesterone. Estrogen and progesterone also feed back and inhibit GnRH. Clomiphene disinhibits GnRH, allowing the axis to progress, stimulating more ovulations. Pergonal effectively becomes FSH and LH. Clomiphene is the right answer. Proguanol also out there. So in closing, I want to reiterate, as you work up infertility, it's about counseling the couple first. After counseling the couple, you want to blame the guy because it's really easy to do with semen analysis. And then you're going to work through the diagnosis of the woman, starting with the mucus workup first, looking for a smush test, treating with estrogen if that's the problem. Ovulations, using any of the methods here, treating with clomiphene if that's the problem. Watch out for PCOS. Working at the anatomy, and if it's an anatomical problem, doing surgery. Finally ruling out endometriosis with a diagnostic lap and laser ablation. And if you finally get to unexplained, it's adoption. You know that there's other alternatives using hormones, surrogates, and the various forms of artificial insemination to get that pregnancy to work. That is infertility.